All right,
All
Dr.
right.
Chung, you're ready to roll, and thank you again for your time.
Absolutely. Thank you so much for having me here. My name is Sandy Chung. I'm a pediatrician, and I'm actually physically located up in Northern Virginia, although right now I'm kind of in the middle of Virginia, near Lake Anna, if you're familiar with that area. It's a beautiful, beautiful place to be, even though it's freezing outside. So, so VMAP, I don't know if you've heard of it. If you haven't, I'm hoping by the end of this, you'll know exactly what it is. And if you already heard it, if any of this presentation's a repeat, my apologies. Sarah asked, how long I'd been with VMAP, and actually I am the founder of VMAP. And we'll talk through a little bit. I'm going to give you a little bit of background and then explain what VMAP is. But I will also tell you how it came to be. So, let's sort of start, and you all already know this, so I will just go through these quickly. But nationally, we know that 1 in 5 children have had a diagnosable mental health condition. And then about half of these psychiatric illnesses start before age 24, for 15, with 75% of them starting before age 24. So it's very much a young adult and child problem. And so pediatricians are aptly suited to manage these conditions or identify the conditions actually before they become severe. We know that families go and see their PCPs, right? It might be depending on the area of the state. You may have pediatricians, you may have family practice physicians, you may have nurse practitioners or PAs. Just depends on the region and the access you have to healthcare. But certainly, you're seeing somebody typically. Although I will say, I grew up here in Virginia, in Richmond, and my parents actually never took me to the doctor. So maybe you don't always see a doctor. But most of us see a doctor when we're little.
Yeah.
So about 83,000 kids, unfortunately, have had at least one major depressive episode. And we also know, and you all certainly know, that kids who have these conditions don't always get care. And then when they do get care, it's not always consistent care. And so Virginia can do better, and we should do better. Suicide is unfortunately the second leading cause of death in our young people, so from ages 10 to 24 years of age. You may be familiar with the Virginia Youth Survey. The Virginia Foundation for Healthy Youth and the Virginia Department of Health do a survey of middle and high schoolers every 2 years. So 2019 was the last time we had a survey. And unfortunately, in that survey, it was identified that 1 in 4 girls and 1 in 8 boys have actually seriously thought about committing suicide in the past 12 months. And that was in 2019. 1 in 3 Virginia high schoolers have felt hopeless or sad for more than 2 weeks in a row. And then 12% of the middle schoolers and 14% of the high schoolers actually have gone so far as creating a plan on how they might commit suicide. Then, of course, you add the pandemic. We know that the impact of the pandemic on mental health has been significant for both adults and children. The Mental Health America survey does a monthly survey, and the one in April and May showed that those kids, 11 to 17-year-olds who already had a diagnosis of anxiety and depression, had an exacerbation of their disease. They got sicker. And the question was why. They were asked, why do you feel worse? And almost universally, loneliness or isolation was the cause. Not COVID, not other things, but that loneliness and isolation that we all experienced when we went through, especially those first few months of the pandemic. And as you all know, this age group really relies on their peer group. And so when they're at home or in lockdown or isolation, that not having access to your friends can be a huge challenge. We also asked our pediatricians. I am immediate past president of the Virginia chapter of the American Academy of Pediatrics, so our state pediatric society. And we did a survey of our members. And what we found is that in July, 88% of our pediatricians and pediatric providers saw an increase in anxiety, depression, and mental health conditions in kids who came to their office. But 62% of them said, I don't know what to do with this. And really, when we talk about VMAP and why it exists, I'll tell you why. So when I am part of a large practice in Northern Virginia. We actually have 22 locations and 120 pediatric providers. It's actually a collection of multiple pediatric practices. And I actually run that group. I'm CEO of the practice. And we were trying to refer our kids, our patients, to child psychiatrists in our community. And the wait lists were just absolutely astronomical. You know, it's 4 months, 6 months long. And then I started to look around the state and talk to other pediatric practices, and they were experiencing the same thing. Health systems were having trouble handling the demand. One hospital system had over 1,000 kids on their wait list to be seen. And so, you know, it was just horrible. We actually had a patient of mine, a 14-year-old with bipolar disease, who came to us because, as his pediatricians, because his child psychiatrist had retired and the family needed help refilling medications. And this was a few years ago. And at that point, we were not comfortable in my practice. We weren't comfortable refilling some of the medicines. They were complicated, and they were ones that we don't typically prescribe. The psychiatrists do that. And so we didn't know how to use the medicines, actually. And so really what we did is said, well, you know, we are your pediatrician, so we're going to help you, but we can't refill the medicines, but we can help you find somebody who can. So we called around and got a child psychiatry appointment for him about a month later. During that month, he ran out of his medicines. And when he ran out of his medicines, unfortunately, his disease got out of control. And he got into a fight, and he got into a fight in the parking lot, actually down the street from our office. And unfortunately, he had a gun, and he shot and killed another man. And that was just horrifying to all of us, to everyone. You know, this child who had disease that was under control, ran out of medicines, his disease was out of control, and could this have been prevented? And I think the answer was yes. And that's what really started our search for a solution. And so, you know, and I'll tell you more about other programs, but really we started looking around to see, is there a way to solve this problem? You know, where we know there are just not enough providers. Over the pandemic period, over March and April, we actually saw, as we all know, you know, when we were in lockdown, most people stayed home. A lot of people didn't go to see the doctor if you didn't need to. So emergency room visits went down. But we did see that the number of visits for mental health reasons went up, and that continued through October, and it's still continuing. Studies from China also showed this, you know, so it really is a global issue. More than 63 studies have shown that basically prolonged isolation can exacerbate mental health disease. There's lots of reasons why this can happen. We are social beings, and so being isolated is complicated and it's not good for us. But certainly depending on the age of the child, the educational status, if they're special needs, if they're pre-existing conditions, if they're in a demographic where they may be challenged, or if there's just fear based on what's going on in our environment, all of these things can make it worse. And then, of course, we had virtual schooling, or we still have virtual schooling. And there are some concerns with that, right? We have different schedules now. We're missing things in school that, you know, I have well, now he's a first year in college, but, you know, he didn't have a graduation. And that was a big deal to miss that. I think I missed it more than he missed it, but either way, you know, these milestones are important in life. And then the quarantine requirements, the changing learning schedules. My kids have gone back to in person, but it has been a challenge because it's, you know, one day, you know, for a few weeks it's no days, and then it turned into 2 days, and now it's 4 days. And so it's a lot of transition for all of us to have during a school year. And then we know not everybody can access learning virtually very well, depending on what they have at home. Mental health treatment actually happens at school too, and you all know that. So 13% of teenagers get some form of mental health at school. And then of those, 35% get all of their mental health services at school. And so in a virtual environment, that can be a challenge. They're certainly trying, but it's not quite the same. We know for housing issues with the financial situation that all of us have experienced. I think we all know that now there are issues with food and housing and insecurities about their financial situations, you know, internet issues, loss of insurance. There is a free resource. I don't know if you're familiar with this. It's called Aunt Bertha, and it is online. It's free. And all you do is you put in your zip code, and this is for families to use, and they can just type in their zip code, and it gives them resources in their community for, food banks, housing, childcare. There's all sorts of things on there. Their mental health resources aren't as strong, but certainly for different pieces of life, there are a lot of great things there to help people for free. And then, of course, the adults, when we look at our kids, we often are experiencing things, and our kids feel it too. And they have behaviors based on what's going on in our lives. So making sure the adults are healthy in the household. Of course, I have 4 kids, so suddenly I became not only mom and doctor and employee and all of those other things. Suddenly I had to be an educator as well. And it's a challenge, right? It's a challenge, and you know that. So making sure that we take care of ourselves, right? That's important for new moms and new parents who are having babies in a pandemic, making sure that they're handling the situation. And then we also know, just with everyone being at home, there have been some increases in domestic violence, and perhaps an underreporting of what's going on, because everyone is in a single home and not necessarily going out where they might interact with people and be identified as having issues at home. So we talked a little bit about, why we need something. So the mental health access program, we did a survey of our pediatricians just before we started BMAP to find out, is this a issue all across the state? Or across the country. So we wanted to see, is there a need? And so when we surveyed our pediatricians, that 98% of them said there's not adequate access to child psychiatry where they are located. 91% said there's not enough access to mental health resources. And then 85% said, given the information I have and the resources I have, I can't handle this. I don't know how to help families. And then 95% said, I can't call a child psychiatrist. The question was, if you needed to just pick up the phone and talk to a child psychiatrist, could you do that? And 95% said no. So I don't know if you know, but when a doctor has a question, like for example, if I had a question about a heart issue, I saw a patient and I was worried about a murmur or something that was happening with that child, I could pick up the phone and call a cardiologist immediately. And they would pick up the phone when I called, and they would talk to me and guide me. And then they might even see the patient that day or the next day, depending on what's going on. And that does not happen in child psychiatry. That's not a thing. I can do that for any other specialty, but I cannot do it for child psychiatry. And why is that? Well, Virginia actually ranks 41st lowest in the country for the number of child psychiatrists and therapists and mental health providers for children. Only 2 counties in our state have enough child psychiatrists for the number of kids in their county. And this is a map that you may or may not have seen. It's from the National Academy of Child and Adolescent Psychiatrists. And on this map, you can see there's 2 counties that are highlighted in green. And at the time of this map, those 2 counties had enough child psychiatrists for the number of children in their county. The yellow ones have a shortage. And the red ones, there's a severe shortage. The gray counties do not have a child psychiatrist at all. So we can see why there's a problem. There just aren't enough child and adolescent psychiatrists. And quite frankly, there never will be. It is not a field that, unfortunately, is terribly attractive to those who are graduating from medical school and choosing their residencies. Unfortunately, it's not valued, it's a long haul, and then it's just not something that people seem to be wanting to go into. Not only that, but we know there's an increasing demand. So what do we do? So then we thought, okay, well, let's create something, and we thought about BMAP. Now, we did not design this program. This is actually a program that is in different flavors across the country. Now there are more of them. When we started, there were probably about 7 programs, but as you can see, this is now growing nationally. And it all really started in Massachusetts. They had the first programs called MCPAP. And they all offer slightly different services, but the concept is the same. So what is it? So in BMAP, we do a few things. There are 4 things we do, and one is education. So teaching pediatricians, family practice physicians, nurse practitioners, PAs, anybody who provides medical care for a child, we teach them what to do. How do you screen for mental health disease? How do you treat it? How do you make a diagnosis? But then once you start doing that work, we're not child psychiatrists. So we do get to the point where we need to call and ask a question. And like I told you, you can't just pick up the phone and speak to a child psychiatrist because there just aren't enough of them. So what we've done in VMAP is we've created a consult line where anybody in our state, any primary care provider seeing children and adolescents in our state can now pick up the phone and call and talk to a child psychiatrist. Not only that, there's also a licensed mental health provider and then a care navigator. So telemedicine, you'll see listed there as well. Certainly before the pandemic, we didn't do much in the way of telehealth. Now it's quite commonplace. The telehealth visits there are really just to help with the consult. So if I call and speak to the VMAP child psychiatrist and the child psychiatrist says, I need to talk to the family to get more information, then they may set up a telehealth visit with the family to get more details. Care navigation is a relatively new feature, new service of VMAP. So in that case, I would pick up the phone as the pediatrician and call and say, I have a family who has a 14-year-old with bipolar disease who needs a child psychiatrist or needs a therapist. Can you help them? And then the care navigator would reach out to the family and call them and help them navigate our system and help them find care. We've divided the state into 5 regions. You can see them here. The stars are where our child psychiatrists are located. Now, VMAP's pretty new. We just began probably 2.5 years ago. So it's grown quite fast. And so when I talk about all those different services with education and the consult line, that is statewide already. So already you can call wherever you are located in Virginia, the primary care providers can call. The care navigation services and the telehealth services are not yet all across the state. So right now in the northern region and in the eastern region of our state, these are the hospitals that are helping us, but now we have care navigation services in those regions. And just to go through how it works, first on the top left, you can see first we educate doctors, we educate nurse practitioners and PAs. If they have a question, they can call the consult line, goes to a call center. And then the call center, depending on what the reason is for the call, will transfer the call either to a child psychiatrist, a licensed mental health provider, or a care navigator. And then if a telepsychiatry visit's needed, that can be arranged. How are we funded? So it's state funded primarily. It is a collection of things. We started with actually volunteer work. So when we began VMAP, there was no funding. And people were volunteering, even our child psychiatrists were volunteering, but that wasn't sustainable. We then were lucky enough to be able to get a grant, a federal grant with the Virginia Department of Health. And then we advocated, and you guys were a part of that, and we really appreciate that. So the advocacy was a tremendous effort, and we were able to get state funds. And then the first year we got half, and then next year we should have the full funding. There are lots of people working on this and lots of agencies working together, which is great. And so we have the Department of Behavioral Health and Developmental Services, BDH, the Medical Society, the AAP chapter. Rachel Reynolds is affiliated with VCU, and she runs our care navigation and call center. We have these different work groups and lots of people working on that. There's probably 100 people working on VMAP at any one time. We do different types of trainings for the doctors and the nurse practitioners and PAs. So the REACH Institute is a weekend-long training followed by 6 months of phone calls. Project Echo is almost a 1-year program where they do 1-hour phone calls once a month and learn. And then we also do quality improvement projects. This is an example of the results of one of our quality improvement projects where we implemented screening. So screening for mental health conditions, screening for depression. And as you can see, as when we started, they weren't doing as many. And by the end, we had pretty good results. In that quality improvement project, over 120 primary care providers started screening using different screening tools. And the issue with screening is most doctors and nurse practitioners, PAs, they don't want to do the screening if you don't know what to do with the results. right? And it's not helpful for the families if you do, right? If you don't know what to do with the answers. So you really need to know what to do. So teaching them to screen is only a piece of this. So it's not only teaching them to screen, but teaching them what to do with the results, and then also providing them supports so that they can manage and help the families. So we have 505 providers registered in VMAP as of March. We've done 780 consults, and we've had 451 providers trained. This is our call volume, so you can see very recently it's starting to grow, which is great. You may have heard of Unite Us. Unite Us is a platform that is designed to help with finding resources, and they have done a contract with the state of Virginia to provide sort of a centralized database, if you will, of resources for families. And so VMAP will be joining Unite Us, and we will actually be helping to build out their mental health services. And that's really exciting. That's just starting. And we're excited about that. So it's going to be a part of the care navigation arm of VMAP. So if a family needs services, VMAP can help them navigate and find resources using Unite Us. This is a little slideshow, or not a slideshow, but a little video of some of the providers. I'll just play that for you.
See, Dr. Chung, we can't hear it.
Oh, okay.
One thing you might want to do is when you share it, just make sure it has audio enabled.
I got it. Let me try that again. Is that better? Can you hear it now?
Yep, we're perfect. Okay. Thank you.
Right.
So I actually used the consult line just last week. And, while the REACH training and, my 12 years in primary care pediatrics as a physician have given me a lot of tools, I had a patient who I was just over my head. And before the consult line would have been available to me, I would have had to send this child to the ER. So to let you know a little bit about this kid and family, this is a child who's been in and out of the psychiatric hospitals 6 times in the last 2 years. Most recently, I am in Roanoke, Virginia. He was admitted to a hospital at Virginia Beach. So 3 weeks ago, this child was discharged to home from Virginia Beach. Their first psychiatrist appointment, because they don't have a local one, he's been in the hospital so much, isn't until 2 weeks from today. He was on 5 medications and hallucinating. He was safe at home, wasn't suicidal, so did not have a reason to be admitted to the hospital again. I was able to call the consult line within an hour, talk to a psychiatrist, and I had a treatment plan. And I called the kid's mom back. She was on her way home because she lives an hour from me in a rural area of the state. And we established a treatment plan, and I'm going to see them back later this week. And that is care that I could not have provided without the consult line. I would have been over my head. I wouldn't have known what to do. Also thinking about what is VMAP doing for us in primary care. There is a real burnout that I've seen happen, I see happen with my colleagues in primary care, where we feel like we know we need to address a need and we may not know how to.
I've been so thankful that VMAP has been there doing the consultation lines. They are responsive very quickly. I get phenomenal advice. I am much more comfortable. I feel like my patients get so much better care by getting advice from VMAP than if I had referred them to a general psychiatrist, somewhere within an hour from here. And I feel my patients are much better cared for. And when I need to get help and do a referral, I still have trouble finding somebody to do a referral with. but I feel like the patient's under good management until that can happen.
Especially when it comes to any need for medication, there is just such a long wait, issues with insurance and so on. And so I just felt like my hands were tied. Now, with VMAP, I feel like I have been able to bridge that gap. And that, has been really, really meaningful. Being able to have, more of an education and background in how to manage these medications. And then when we are limited still in our knowledge set, to be able to call the psychiatrist and get, that feedback to intervene has been just a huge, huge lifeline to basically bridge that gap. These families would be just waiting for months and months without any help otherwise.
So luckily, the VMAP program was there. One of the prongs of the VMAP program is education. And through the education prong, I've been learning a lot about how to screen for depression and anxiety in adolescents and how to manage it and treat it.
I remember my very first mental health patient that I took care of as an attending. And this patient came to me in a checkup, and she was severely depressed, getting to the point of being suicidal. And I knew that I needed to do something now to help her. So I walked out of the room and went over to one of my colleagues who I know does a lot of mental health and has prescribed a lot of medication. And I was like, I need help. And they handed me all of these different tools that I could give this patient, walked me through some basics about how to start the medication. And I did all of those things, and I felt, wow, I think I just really helped this patient and made a big difference. I don't feel comfortable doing this at all on my own, but it's here and I'm going to have to do this to be able to take care of my patients. So I was very fortunate to be given the opportunity to participate in the REACH conference within a few months of being an attending. And it was offered free of charge for many of the people that are in my local community. Several people from the practice where I was working, we all went together, and it was the most impactful CME course I have ever had. I walked out of those 3 days and transformed my entire practice. I started screening more readily for mental health concerns at every single checkup. I felt more comfortable evaluating patients and diagnosing them with things outside of just ADHD, but really getting into more anxiety and depression. I started doing a lot more medication, getting a lot more comfortable with all of that. And now I can definitely say that mental health is a very large part of my practice, and I see patients every day, treat patients every day, and VMAP has been extra helpful at this point because I feel quite comfortable with a lot of the kind of straightforward issues. But then when it gets a little bit more complicated, it's amazing to be able to pick up the phone and get in contact with a psychiatrist and get advice that then I can use not only for that patient, but for when I move forward and take care of other patients.
About a year and a half ago, I did my first conference with our Project Echo, the year-long group. And so I just completed that, I want to say August of this year. And after that, immediately signed up to do the deeper dive for the younger kids between 0 and 5. And then was connected to the REACH conference as well, which myself and one of the physicians at our practice just completed. And so I feel like I've learned a ton. I feel like my skills have grown because of that. It was great to hear from not only psychiatrists, but also from pediatricians. I feel that my understanding of a lot of these conditions, ranging from depression to bipolar disorder, has grown, and I know that my comfort level with more complex conditions has grown. And then more recently, I've been able to also use the VMAP line for one of my patients that unfortunately is unable to follow through with psychiatry appointments. And so we have been managing his condition, and I feel like he's tried more medicines than any of my other patients. And I was able to reach out to a psychiatrist through VMAP, and they called me back in like 5 minutes and gave me some recommendations for what to do when he comes in next.
Great. So hopefully that gives you some idea of how VMAP's being used in our state, and we're continuing to grow it to provide more and more services. Just a few notes about VMAP. We do right now, we serve patients up to age 20 through 21, so up to their 22nd birthday. I certainly know that there's a need for older than that, and also some focus on the really young age group, 0 to 5. So those are all future states of VMAP that I hope we'll be able to expand to soon in the next couple of years. It isn't a line though for families to call directly. So this is really targeted to the providers. And so I would love to chat a little bit about, how we might get more primary care providers to know about VMAP so that their families can be helped through them. And then they can certainly do consult requests online. It is for Virginia patients only, since it is state funded. We have lots of partners. This is not an exhaustive list by any stretch. So we're so pleased to have so many people working with us. And these are some contact information and things. And so, you're welcome to reach out to me or anybody on this slide. And that's all I had. I'm happy to answer questions or have a conversation, whatever seems to work best.
Thank you so much. That was great. I see Karen's hand, so I'm just going to call on her first.
I first heard about this about a year and a half ago, and it's really a pleasure to see how much it's moved on and continues to grow. And it's so on the spot, obviously. The thing that had me a little concerned is that the focus does seem to be on medicines. There is a terrible shortage of psychiatrists. What about therapists?
Yes, absolutely. So the way it started was, obviously, since I'm a pediatrician, looking at how can we help that child psychiatry shortage. But you're absolutely right. Medicines, often we don't want children to be on medicines, right? So it's not the answer. When we have medicines, it's nice to have the consult line. What we've added to the consult line now, and the folks that were in the video, that didn't exist when they had used VMAP, is that we actually have licensed mental health providers answering the phones first. So when someone calls, when a pediatrician or family practice physician, PA, NP calls, there's a licensed mental health provider in the northern and eastern region. So the 2 hubs that are fully fleshed out, the other hubs are coming. So by the end of this year, we'll have all 5 of them. Then what happens is the licensed mental health provider actually talks to the provider first, because it may be very much, that it's not a medication question. Right. If the child's already on medicine, that's one thing. But if it's a new presentation or something's happening, often it can be handled with therapy, with different types of services. Perhaps it may not be residential, maybe it's not emergency room, maybe there's something in between. I will tell you that pediatric training is very weak as far as teaching us all the different levels of mental health services, like IOP, all the acronyms. Totally new to me. I had no idea what most of these were. And it's because we aren't taught that when we go through our training. So that's a gap, and that's a gap that we're addressing. We're directly addressing it by having the licensed mental health provider answer the phone so that they can really help direct them. Yeah, does that help?
Yeah, thank you. Good news.
Yeah.
Yes, thank you. Good news.
Anne, I see you. Go ahead if you're ready.
So I had a question. Dr. Chung, we met a couple years ago when you were just starting out. So I'm so happy to see the progress you've made and how you've stuck with it. And I know how much hard work that's taken. So you may already be aware of this, but I just wanted to make sure everybody knew what everybody else is doing. So there was a youth summit between the American Association of Pediatrics, American Foundation of Suicide Prevention, and the National Institute of Mental Health. And I was one of the keynote speakers for that event. And for that day, I was able to be in some of those small groups, but they went on for a couple of weeks having these small groups. So I just want to make sure that they're aware of this program and what you're doing, you know, as they're doing that big blueprint and that planning. So I'm sure that you probably already know, but I just wanted to make sure.
No, no, thank you for that. And no, I don't necessarily know. You know, I think what I'm learning is it's such a big problem. A lot of people, not everybody, but everybody's working on it. And what we do end up sometimes is being in silos. It's so much better when we're all working together. We're so much more impactful. And so I think maybe afterwards you could, I don't know if you still have my email address, but
I do. I took a screenshot of it.
Oh, great. Can you email me that? Because I think, while I think I know what you're talking about, because I recall a summit happening, it was pre-pandemic. And so,
this was in February.
Oh, then I don't know what you're talking about. Then absolutely.
Recent.
Oh, okay. Then I would love to learn more about that. Yes, absolutely.
And I also would like, and this is another set, I'd like to get you in touch with a woman. She's another pediatrician, and she does a podcast called Pediatric Meltdown. And okay. I think that you would make a great guest for her show. So I'm going to also do an email introduction between you and her.
Oh, thank you so much. Yeah, I'd love to meet her. Thank you.
Janet, go ahead.
Yes. Cindy, I'm interested in, that sounds like you do fantastic things. Does that offer continuing education credits for people? Because yes. I understand from practitioners that those are hard to get, so.
That's right. So yeah, so we definitely, the training programs all offer the continuing medical education credits. And then also something else called maintenance of certification, which we all need to maintain our board certification. Right. So yeah, so we definitely offer those. And it's a nice part. A lot of people are, it's interesting, you know, I think what early in this, someone mentioned, you know, how do we engage primary care providers? Mm-hmm. And what we find is that they're kind of fall into groups of three, you know, so there's one bucket of primary care providers who really want to learn this, right? They're just interested and they want to figure out how to do this. There's a middle bucket, or actually the last bucket is, I don't want to ever touch this, right? I didn't become a psychiatrist for a reason, right? I became a pediatrician. That group, you know, we'll see what we do with that group. But then there's this middle group. This middle group is either learning this because they have to, right? Because there's no child psychiatrist near them. Or after they see their colleagues do it, then they also do it, you know? So there's, and I'm sure there are other reasons in there, but I think if you can get 2/3 of primary care providers comfortably managing some level of mental health, that's amazing, you know, and it's so much better than where we've been.
I have another question. In talking to practitioners, one of the most greatest concerns that they have, and I can't imagine in trying to do referrals, are insurance companies and all their ridiculous rules for whether they treat or don't treat, or a lot of the practitioners won't accept the insurance because of all those rules. Have you dealt with any of that?
Yeah. So in my other job as a CEO of Trusted Doctors, I actually do all the contract negotiations with all the insurances. So I spend a lot of time with insurance companies. And what's interesting is that now in the insurance space, they're recognizing the impact of mental health on physical health, right? Mm-hmm. And yeah, so they're starting with the adults. So they're starting to recognize that, hey, you know, maybe we should address mental health, and maybe that'll help. And so, and so the other piece that has traditionally been in the past for the payers is you had 2 different buckets of coverage, right? You had behavioral health insurance coverage, right, and then you had medical health insurance coverage, and they did not cross, and the providers did not cross. And so I think there is a movement to trying to break down those silos. It's really starting more with actually consults, like kind of like what VMAP does, where a primary care provider consults with a behavioral health provider. Sometimes they're helping to support an embedded mental health provider. So like if your clinic is large enough and you can have a space, office space for a behavioral health provider, bringing that together. But as far as like psychiatrists getting paid, one of the issues in Northern Virginia, at least, is that there are child psychiatrists, but most of them don't take insurance. And because they don't take insurance, it basically means they're not there, right? Except for their pitch, right? And so will they ever come back? I can't imagine that they would, because as long as there's people who can afford it and will see them, then they don't need to take insurance. Right. What we do need to do, though, is that our new child psychiatrists that are graduating now support them. Right. We need to support them, and the insurance companies need to support them so that they don't follow that same path. So I think there's that. And then again, that alignment of primary care and child psychiatry is happening more and more. And so I'm hoping that also will prevent this thing where they don't take insurance.
So does the insurance interfere with any of the referral kinds of things that you have been talking about?
Oh, yes. I mean, well, first of all, whether they may not, I would say that they interfere with the referral, but rather there's fewer people to refer to.
Yeah.
Because they don't take insurance, there's just a handful. Usually they're affiliated with like a hospital system because the hospitals all take all insurances. And there are just some weird little rules, like Medicaid won't pay for certain medications if a primary care provider prescribes them. They'll only pay for them if a psychiatrist pays for them. And so that doesn't make any sense, right? I mean, because so there are little nuances to the insurance that still need to be fixed, but we're certainly advocating for that in the pediatric space. So.
Kathy, go ahead.
Is there a way to find out which pediatric practices in your area are involved or pediatricians with the VMAP program?
Yeah, that's a great question. When we first started, it probably wouldn't have made sense to do that because there weren't enough, right? But I do think we're getting to that point now where we have pediatricians and providers in all the regions. So we have talked about that. We do have them enroll in VMAP, so we know who they are. Okay. And if they've gone through their training, we know who they are. And so there is some discussion about being VMAP trained or VMAP aligned or something like that, and putting that on our website somewhere. But we're not there yet, but we're just getting to that point where we have enough people trained, where that makes sense.
Well, the reason I'm asking is, I mean, I don't know NAMI as ambassadors or whatever. If you had some sort of flash drive or something, we could visit pediatricians' offices to make them aware. I don't know how aware they are. I'm sure you have sent it out to all of them and remind them, but sometimes, you know, the in-person visit or something helps sometimes. And you say that the training is free, correct? And it's online at the moment.
Now it is, yes.
Now it is. But I mean, you know, if we had a fund where, I know we did it when CIT began, where you offer to pay their room and board for the weekend, or if they need materials when they do this, you know, we could offer to pay that, you know, a partnership.
Sure.
Do you have things like that in I mean, for us to help you get it moving.
Yeah, we would love your help. I mean, really, what we're trying to do is identify the more primary care providers, right? And so we're particularly, we are looking at the populations that we serve and trying to make sure we're being as accessible and equitable as we can be. So in particular, if you know of groups or primary care providers that are serving high-risk populations or underserved populations, we're very interested in trying to reach out to them. When we first started this, it did start kind of in Northern Virginia. That's where I'm located. So it was a lot of word of mouth. And then we went down to Eastern near CHKD. Now we're in Richmond. We've done some in Charlottesville and Lynchburg and Roanoke, but they're still kind of city centric. You know? And so we are just now partnering with Mount Rogers and trying to move also down in the Southwest, trying to recruit more primary care providers. But that's where we really need help, is to get the word out.
So you need more PCPs, not pediatricians.
Right, that's right.
Okay.
So family practice physicians, nurse practitioners, as long as they take care of children and adolescents, that's what we're looking for. So
okay, so both.
Yeah.
But do you have any materials if I should contact you that?
Yeah. Is there? I
Great.
wonder if Sarah, I could send you information that you could pass to everybody else. Would that work?
That would be perfect. Thank you.
Okay. Great.
Okay, because that's our NAMI's focus. I'm thinking it's focused. We've got some money in that category. Let's do it. This
Yeah,
is
that's fantastic.
yeah.
We'd love your help.
Yeah. Okay.
Excellent thought, Kathy. I love it. And Kelly, I saw your hand, and then we'll go to Summer.
Great, thank you. Hi, Dr. Chung. I met you several years ago when you came to Fairfax CPMT and talked about your program, and I'm impressed by how quickly it has caught fire, and that's really wonderful. I think pediatricians certainly benefit, and as you say, more primary care. One of the questions I have, and I think this is you mentioned the education piece of the program, and I think we all know, especially as family members, that one of the challenges in making sure that treatment is delivered to fidelity is making sure that there's that family buy-in, that the services, the treatment plan is family driven, is culturally relevant for that particular individual and their family, and so I hear that you're doing the hard work of getting the information, the scientifically based, medically proven information to the pediatrician or to the provider, but is your education also taking in that really tricky wicket of making sure that they have the skills to match that treatment plan to the needs of that family, so that whatever's recommended is actually going to be implemented?
Sure. And what you're talking about is really where the entire field of medicine needs some work. And so, right, not just mental health, just all sorts of things, right? And so I think what we're doing, it's certainly, we do motivational interviewing skills, that type of work is built into the educational program. However, there's always room for improvement. Right. And so I think figuring out, and what's interesting, and this is probably more than you want to know, but in medical school education, they're actually very focused on that right now, and teaching physicians in training to start to work and think that way. My generation, when we went through, it was do your basic sciences, and then, let's do a couple of years of clinical. Now it's totally different. The day they walk in the door, there's a patient in front of them, and they're starting to understand that how to make this human and also how to work with families as opposed to telling families what to do, right? So it's a transition in the culture of medicine generally that's happening, not just in mental health, but in mental health particularly. You need the buy-in, not just of the parents, but of the child, right? And that's really challenging. I have 4 teenagers, so it's very challenging. And so So if you know how to get my 4 teenagers to do what they need to do, just send me an email. But seriously, I totally hear what you're saying. I think if you have anything in particular you're thinking of, I'd love to get some more information. Our programs continue to evolve. So I do want to, optimize what we're doing, since we are talking to so many pediatricians and family docs now.
Yeah, I think NAMI could actually be a great partner in that, as you deliver, whether it's virtual or back in person, sort of teaming family members in that training delivery. That has worked in other smaller venues, and that may be a really meaningful piece.
Yeah, I love that.
So thank you. Thanks for being open to that conversation.
Absolutely.
Yeah.
Thanks for volunteering.
Yeah, Kelly's amazing. So we, would love to tap her, and she's absolutely right. We've got a wealth of lived experience. And I know you recently launched an advisory committee, which we had been recruiting folks for. So I think that'll also help have that voice of families represented, and we highly support that move. So thank you, Dr. Chung. Summer, did you have a comment you wanted to share as well? You're on mute, Summer.
Of course, so sorry. Dr. Chung, thank you. This was really informational, and I appreciate it. I was wondering if there are opportunities to partner with you to get information out. I know you were going to send us information, but a chance to partner in, I don't know, public videos or media or something like that, so that we can get the information out more publicly. We were recently contacted by an insurance provider because they are trying to get information to their members. And I thought maybe about doing one of their town halls or something like that. So I just wanted to see if there were opportunities to partner with you besides just emailing information out. So
of course. Oh yeah. So really, the VMAP doesn't work if people don't know about it. So as much as we're able to talk about, and I would do that in a bi-directional way. So I don't know if NAMI Virginia needs additional, because I heard you say, how do we reach primary care providers, right? So I'm sure that primary care providers, a lot of them have no idea what NAMI Virginia is. Right. And I didn't actually recognize, you all heard me talking to Sarah in the beginning, I didn't recognize that there are 14 divisions of this. So, it's eye-opening to me, really. And you all are a fantastic resource. As we talk to families and we identify something, you all are a fantastic resource. So I think it goes both ways. Let us also help to promote what you all do to primary care. And then you help us find more primary care. So, yeah, but I'm happy to, and maybe, I don't know who to work with here, if it's Sarah or who we should be working with to kind of identify ways to work together. Or if we just want to email me directly, that's absolutely fine too.
So it's a great question. And I will say that I'm going to share this video and your contact information, and affiliates are welcome to reach out to Dr. Chung directly. But, I would love to kind of work with you on sort of a outreach toolkit that our affiliates could kind of use to do some education. Because I have questions like, who should they be targeting for the different trainings? Where are things statewide? Where aren't they? I had a question for you, particularly it might be helpful for folks on this call, but in terms of the family navigators or the navigation, I get that if I have a client or a patient that I think needs some help, they're kind of close to crisis, they need someone to walk them through it. Could you offer some insight on, is that like a one-time callback? Is there a bit of a relationship? What's sort of the expectation for that service?
Yeah. So I actually, it's a one-time sort of referral, I guess, not even an official referral. So it's helping it's not just one time though, actually, I take that back. So we call the care navigator calls the family, right? Sort of figures out what the resources are. Then we have a database we're using, and I know you all also have a tremendous database, and I'm pretty sure we've talked, like you and Bernadette have chatted, or somebody's talked to NAMI Virginia about trying to unify that a little bit. So, but there could very well be an instance where we refer to you all, and then you take it from there, right? I mean, our care navigator is not meant to be there for ongoing resources. We do a follow-up to make sure they got to where they needed to go, but you may be actually who we refer to, right? So
that's great. I was just sort of curious to get some insight on that. And yes, I mean, we've talked to Allie about our programming and the free peer-led services we offer, and she's got that information. We'd be happy to, be connected with all your hubs just to keep them up to date on our resources. So that was sort of, I think our goal is to kind of help build your level of resources, but also get more PCPs watching for and serving children that need that help.
Right. Yeah, we are not here to be the resource, right? We're just here to try to connect, just like you all, right? So, but connect to you so that you can connect, so and help the families. So the groups, the families that we identify are the ones who show up at the primary care providers. There is this whole other arm of pediatric mental health in a school-based setting that is addressed in a different silo. And I do think that there's room for improvement there, right? So how do we, when a school identifies something, how do they get them in touch with, someone like you all? Do they need, screening, diagnosis type things, and in which case they might come to us and to you all, so I think there's an interesting, not interesting, but a necessary interplay between school, the pediatricians, the families, and trying to make that not so chaotic for a family where they have to go from one place to another, to another, to another. It's so hard. So.
Great. Any last questions for Dr. Chung?
I just have one. I've interviewed school counselors from around the country for a book I wrote that's not out yet for teachers. And a lot of them do have a set protocol that they have people that they consult with. Like there was and I think schools are working towards that now. Some of them have more sophisticated systems than others, but I think we're all kind of working towards the same goal. But I do know there was a school counselor in New York who had a really solid protocol on how she worked with, her outside resources. But she could do the assessments in the school setting because she's, got a PhD, but most schools don't have that resource. So that was just real fortunate for them.
Yeah. Certainly seems like a solvable thing. I tend to think operationally, but it will take a lot. And there's a lot of history and a lot of protocols and bureaucracy that sometimes stands in the way. Right.
Great. Kathy, did you have one more? Did you have a question? Okay. All right. Well, thank you so much.
My finger up to my husband. So.
Great. Well, Dr. Chung, thank you so much. I'll follow up with you to get some strategies in place. And I really appreciate your time tonight.
Thank you all so much. I really appreciate it. Look forward to working together. Appreciate it.